Hello, everyone. Thank you. I hope you're enjoying your lunch. My name is Lillian Ringsdorf. I am the medical director for the Texas Department of State Health Services Region 8, and I've been involved in developing a district project in RHP 6 where we're finding high-risk individuals, screening for latent TB infection, and treating them with the goal of lowering TB disease across the state of Texas. So it is my honor to be able to introduce our speaker, Dr. John Hellerstedt. Dr. Hellerstedt serves as Commissioner of the Texas Department of State Health Services, leading one of the state's largest agencies with a staff of 12,000 and an annual budget of $3.3 billion. As Commissioner, Dr. Hellerstedt oversees programs such as disease prevention and disaster preparedness, family and community health services, environmental and community safety, regulatory programs, and mental health and substance abuse prevention and treatment programs. Dr. Hellerstedt became Commissioner on January 4th, 2016. Prior to becoming Commissioner, Dr. Hellerstedt served as Chief Medical Officer at Seton Family of Hospitals. He also served as the Vice President of Medical Affairs for the Dell Children's Medical Center of Central Texas and as the Medical Director of Texas Medicaid and Children's Health Insurance Program at the Texas Health and Human Services Commission. Dr. Hellerstedt earned a Bachelor of Science in Chemistry, graduating with high honors from Allegheny College, and received his medical degree from Pittsburgh School of Medicine. Dr. Hellerstedt completed his residency in general pediatrics at the University of Texas at San Antonio Health Science Center and is certified by the American Board of Pediatrics. So I'd like to welcome Dr. Hellerstedt.
Thank you, Dr. Ringsdorf. Appreciate it. And it's a great honor to be here and be the keynote speaker. And I'm going to talk a little bit about DSRIP. I have had some involvement with DSRIP for over several years now, beginning with sort of when it was a concept and what are we going to do with DSRIP. I must say that I am really, really impressed with the amazing depth and breadth of what's taking place in terms of DSRIP. And I can assure you that I value what's being done and see its potential to transform healthcare. So it really is a great honor for me to be here. Am I flipping my own stuff? Is that way? Do it yourself? There we go. So we want to talk about DSRIP and public health and the common goals. And obviously, we're both seeking to improve health outcomes while containing costs. And as you all know, that's really not an easy thing to do. It's much harder than it sounds. And a lot of, I think, the themes that we'll talk about here and that you all have experienced in doing your DSRIP projects is the ability to engage and motivate the patient in terms of their behavior and in terms of their access to care. Transforming healthcare in Texas. Over the past 5 years, our delivery system reform incentive projects have been focusing on the transformation of healthcare. And the 1115 waiver has given hospital systems, local health departments, local mental health authorities, and academic science centers the opportunity to develop and test initiative strategies that would transform how healthcare is delivered in Texas. And much of the work through the waiver has been pursuing the triple aim, which is the approach of transforming healthcare that focuses on improving the individual experience of care. What's it like for the patient to navigate the system and receive care? Were patients satisfied with the care that they received, or was the healthcare of high quality? And it also intends to improve the health of populations and reduce the cost of care. And of course, our real measure, ultimately, we want to be the measures of the health status and health outcomes of both individuals and populations. In transforming healthcare in Texas, there are more than 1,400 projects across the state, bringing a wealth of data based on the outcomes consistent with a triple aim. And these breadth of these projects includes decreasing preventable infections, reducing emergency department visits, improving birth outcome, increasing access to health care and mental health care, and improving, again, the overall quality of the patient experience. And we've heard from many projects about the number of new relationships that have been forged across the various components, if you will, of the healthcare system, and creating those new collaborations. And those collaborations have changed how healthcare is delivered within the systems, particularly with regard to mental health and specialty care. But achieving those outcomes, as you well know, takes time and it takes effort. Oftentimes we want transformations to occur quickly, but really when you think about the enormity of what we're talking about in the healthcare system we have in the United States, it's quite a task. Healthcare in the United States, is it really a system or not? I mean, I think some people could argue as to is it a system or is it kind of a series of silos of care? But clearly, in order to get that triple aim, to have the patients experience, have a good experience of healthcare, and really that experience translates into their willingness to essentially use the system appropriately, because if they feel like they know how to get what they need for health out of the system, they're going to be more likely to use the system in the most efficient way. And we want to engage patients, which takes time. It takes forging relationships, and transforming our healthcare system involves changing the culture of how healthcare is delivered to better meet the needs of the patient. And we're looking for success in that endeavor, and it requires an awareness of the multiple factors that influence the health of Texans. And so what I want to talk a little bit about here are the leading causes of death in Texas, and this is where I think we are talking about the merger of healthcare delivery and population health and public health, which the more I'm involved in public health, the more I feel like all of those things are intimately connected with one another. And we still face significant challenges, particularly in addressing the causes of death that are shaped by behaviors of the patients, such as death related to unintentional injuries, tobacco use, and being overweight and obesity. And I'll be sharing some recommendations on how to achieve this transformation in our healthcare system through the words of your colleagues, in other words, folks from who are doing disrupt projects around the state. And we need to discuss what issues must be addressed with the individual who's accessing health care services in order to better prepare patients for achieving success on their own healthcare journey. And here are the determinants of health, and I would draw, if you will, particular attention there to the great big light green area. So social and economic factors, we know that plays a tremendous role, as well as health behaviors. And if it shouldn't surprise you if you work in healthcare to see that while there is a place for the physical environment, genes, and biology, and the delivery of care, by far the biggest determinants are socio-economic and behavior related. And before I became commissioner, as was mentioned, I was the chief medical officer for a healthcare system of 11 hospitals here in Austin, and the biggest part of my job was to try and change the behavior of physicians. So I know how difficult it is to change the behavior of people. So many factors affect the health, as you can see there. And people are, how do you get people to stop smoking? How do you get them to reduce their alcohol consumption? Those are all very difficult problems. And the physical environment also can play a major role in healthcare. You've probably, I hope, at least seen maps to show a correlation between things like childhood obesity versus the opportunity for kids to access a park and have recreation and be able to go outside and just blow off steam and get the kind of natural play-oriented exercise that they have. And it correlates remarkably directly. The fact that society has changed in a way, and kids don't have the opportunity that they had, certainly in my generation, to just go outside and play. And we're paying a price for that. want to talk about the social determinants of health in Texas. And obviously, education is part of it, but interestingly enough, when I was in practice here in general pediatrics in South Austin, I had a really diverse patient population in my practice. We had folks on Medicaid, also had folks who were professors at this university. And what I'll just sort of comment and say, yes, education can play a role, but it's surprising how little education we give even to the smartest people with PhDs behind their name in terms of understanding their own body, of understanding the basics about health care, how to access health care, and basic concepts of disease. Here we can show that, excuse me, according to the 2015 America's Health Ranking, from 2014 to 15, the disparity in health status by education level increased, though, which is a bad trend, obviously, from 28.3% to 34%. So that educational level is becoming a bigger factor, and we are beginning to see a spread, I think, in terms of the disparities that are there in our healthcare system. Race and ethnicity also have an impact on an individual's health outcomes. Infant mortality rates are significantly higher among African Americans than whites or Hispanics in Texas. Excuse me. Income levels play a significant role. In 2015, people who earn less than $25,000 bear with me. I think there's a piece of salad somewhere in my windpipe that it may take some time to. Is there an ENT doctor in the house? So if I could get quickly a scope, might take care of it. Income levels have significant impact on multiple health outcomes. In 2015, people who earn less than $25,000 a year were 3 times more likely than those who earned between $50,000 and $75,000 a year to have a poor physical health day. The next is a map of Texas in terms of by-county health rankings, and basically you can see the change here between 2011 and 2016 data. I would draw your attention to the fact that there are many counties in here where we basically don't have data for, and that's a shame. I think that's something that we really want to work on. The lighter shades of blue and white indicate those with higher ranking of counties due to better outcomes associated with health-related factors. The gray counties indicate counties that were not ranked due to an insignificant amount of data being available. However, the counties in which we have the darker shade of blue, such as far west Texas, East Texas, and the Rio Grande, we know that we are still facing challenges addressing various health factors and the impact they have on health outcomes for individuals in those areas. But with 254 unique Texas counties, each has its own unique healthcare needs, and the individuals who come into our healthcare system are obviously just as unique as the counties that they live in. In determining addressing the social determinants of and perceived barriers to improving health care, social determinants of health may influence how successful an individual may be in being actively and fully participating in their own health care. I certainly, from my clinical experience, know that to absolutely be true. And over and above the social determinants of health, of which many people are unable to change, other barriers exist for clients who may impact how much or how little a patient may engage in the various healthcare programs that are available to them. And barriers such as language set up roadblocks for the patient's ability to communicate and to receive information from his or her healthcare provider. And transportation, obviously, is also a significant barrier. Some families really basically can't get access to health care, and many times they can't get access to health care in the way that we think would be the most appropriate way. In other words, they're going to be seeking their health care in the emergency room, which clearly is a higher cost. I'll tell a story about myself. When I was A few years back, I decided I was having a kind of abdominal pain that I thought really needed a workup. And then I thought to myself, well, okay, I have two choices. I can go to my primary care doctor, in which case I've got to talk my primary care doctor into doing the kind of tests and workups and referrals that I think I need. Then maybe he'd do it, maybe he wouldn't, and then I would have to go to the specialist or specialists that they referred me to and talk to them and convince them, and then I'd also probably have to get some imaging studies and this and that sort of thing. So sort of did a calculus in my own mind and said to myself, well, you know, that's like 3 or 4 doctor visits and however many co-pays, et cetera, et cetera. I said, or I could go to the emergency room. Now, I had a $120, $125 copay to go to the emergency room, but then when I looked at all the other factors, I said, yeah. So I said to myself, you know, if I show up at the emergency room at 6:45 on a Sunday morning, I'll check in, there'll be no one else there. By the time I'm ready to be taken back, it'll be the brand new crew, the day crew will have started. They'll be happy to see their first patient, and basically they're going to work me up if they think I need a workup. And you know what? I was absolutely right. That's exactly how it happened. And so I think, when I say we, I think I mean in particular policymakers, we need to be really careful about understanding what people are thinking about when they make choices about accessing health care. And sometimes they are very, very rational choices, even though we think they may be more expensive. And they are more expensive. And again, obviously, given the story I just related, if I were in a situation where I didn't have transportation to even consider the option of going to my PCP and then the referrals and then the other testing, that wouldn't have even occurred to me. So food, shelter, and other basic needs are often at the forefront of families' minds when they're making decisions. And when the most basic needs are not being met or barely being met, healthcare needs tend to be less of a priority. And those barriers create perception that patients are not compliant or that they don't value their own health care. And lessons from DISRIP. I'll let you go ahead and read this. This is a quote from one of the folks who was in one of the DISRIP projects, and they identified diabetic education and case management program was their project. And the quote here really demonstrates the choices made by many patients being served by DISRIP projects they have to make difficult choices on a daily basis. And situations impact how well we achieve these metrics and milestones where folks don't have necessarily the breadth of options that many of us do. And I'm going to select a few projects that are addressing public health issues, smoking and tobacco use, obesity, diabetes, and tuberculosis to illustrate how they transform the system in ways that we think are going to be beneficial. I appreciate the honesty that many of you included in your summaries of the lessons learned and the challenges, as they are perfect illustrations of the magnitude of the task that we really have to undertake in order to transform healthcare. And in this quote above, by the way, the PHQ-9 is the Patient Health Questionnaire. It's a multi-purpose instrument for screening, diagnosing, monitoring, and measuring the severity of depression. So next, I want to talk a little bit about obesity and diabetes. And here you can see some statistics relating to Texas. Texas has one of the highest obesity rates for adults in the United States. The 2015 America's Health Rankings ranks Texas 40th in the country due to its high rate of obesity in adults. Overall in Texas, just over 30% of adults are obese, which is a BMI of 30 or greater. And the chart demonstrates the differences in obesity rates among different racial and ethnic groups. And obesity rates are highest among blacks in our state. Here again, more bad news, if you will. Obesity is on the increase, and for approximately the past 25 years, obesity rates have steadily increased by nearly 160%, from 12.3% of the adult population to nearly 32% of the population. And that trend continues to increase and has increased as much as 9% between 2012 and 2014. And next, obviously related, very closely related to obesity, is diabetes in Texas. And according to the Robert Wood Johnson Foundation's 2015 report on the state of obesity, if the current rate of new cases of type 2 diabetes continues until 2030, the rate of adult onset type 2 diabetes will increase by 45% compared to what it was in 2010. And as we know, diabetes is a really major factor in many other diseases and many other conditions. Diabetes, among other things, affects your underlying ability to have good wound healing and things such as that. So other types of health care that you might encounter, surgery, that sort of thing, your ability to recover from that and benefit from those things is going to be impaired if you're diabetic. And we also know that if people come into the hospital with uncontrolled diabetes, and I don't mean necessarily diabetic ketoacidosis, but just their glycemic control is very poor, they often experience longer lengths of stay in the hospital, and they experience more complications. So diabetes and obesity are one of those things that are sort of multipliers of other morbidities that are encountered. Next, diabetes and obesity-related outcome disrupt projects. There are 211 projects that have been included, 253 diabetes and obesity-related outcomes, and you can see the list there. Hemoglobin A1C control, blood pressure control, uncontrolled diabetes admissions rates, or diabetes 30-day readmission rates are all among the projects that have been undertaken. Talking more about diabetes-related disrupt projects, there are several approaches that are being taken to address diabetes and obesity. One local health department is implementing a diabetes education and case management program that includes foot exams, routine eye exams, hemoglobin A1C monitoring. And through other partnerships, the program is also collaborating with community partners, including an integrated behavioral health clinic to place hemoglobin A1C analyzers into charity clinics at no cost to the clinic or the county, allowing providers to have instant results to share with patients and use at the time when they have that teachable moment and that encounter with the patient over their disease. I want to talk about, continue to talk about the diabetes-related district project outcomes. And among these projects, there have been several positive outcomes that have already been demonstrated. One local health department project implementing diabetes education and case management program has seen a 19% decrease in the average hemoglobin A1C levels of its participants, and that to me is quite remarkable. A local mental health authority working to integrate care for persons with severe and persistent mental illness has demonstrated a 14% increase in persons with schizophrenia who have been screened for diabetes. This is especially important since mental illness and chronic illnesses such as obesity and diabetes, again, are comorbid conditions, and not just comorbid with physical diseases, but also with behavioral health conditions. And additionally, one project has seen a 50% decrease in the number of emergency department visits that were for preventable conditions related to diabetes. And again, that's huge. I mean, that to me is the kind of thing that DISRIP is all about. It really is all about learning how to transform and move the curve, if you will, in healthcare. Talk a little bit about lessons from DISRIP. One of this is again a quote from one of the DISRIP providers. One of the providers noted these lessons learned from their diabetes-related project. It speaks again to the challenge of addressing behavior and behavior-related outcomes, but identifies where providers can play a key role in supporting the behavioral change that's necessary. Next, I want to switch to smoking and tobacco use. And smoking in Texas, in 2015, Texas ranked 5th in the United States in the percentage of adults over age 25 who smoke. So that's fifth good, it's fifth. It's not bottom fifth. And I'm very glad to see our state ranked well in a public health measure as important as that. And so the county health rankings listed Texas as having the 5th best smoking rate in the United States. Give yourself a pat on the back, but don't pass around a cigar, whatever you do. There you go. Here's a graphic representation of adult smoking trends in Texas from 1990 to 2014. And the percentage of adults who smoke on a regular basis has remained fairly stable, with a slight decrease in use beginning in 2004. So we still have more to go. Recent behavioral health behavior improvements in the past 2 years, the percentage of adults who smoke, who reported that they smoke on a regular basis, decreased from 18.2 to 14.5, and that's a 20% decrease. And again, we're really kind of, as you can imagine, you know, we're getting into that population that's harder and harder to motivate, harder and harder to reach and get them to change. So I think the fact that we're continuing to have positive change in that area is really good. We have some smoking cessation-related disrupt projects. There are 8 disrupt projects that are focused on tobacco use prevention and cessation, including projects by local health departments, hospitals, and local mental health authorities. Some examples are focusing on the at-risk youth through using Aspire, a smoking intervention experience, targeting other populations who may have greater prevalence of smoking, such as persons with HIV and AIDS, incorporating clinical practice guidelines to assess and record the smoking status of patients and connect them with resources to quit, like the DSHS quit line, and also media campaigns. Other smoking-related disrupt projects and their outcomes. We have some listed here. One local health department indicated they had seen a 43% increase in the percentage of patients who were screened for tobacco use and who received cessation counseling and intervention. That's great. The adult smoking prevalence rates in specific projects varies considerably based on the numbers served of the project or how the intervention was built. 5 hospitals are tracking the measure about how much support, whether it is advice to quit or discussion of cessation strategies, and healthcare providers have offered patients who report that they are smokers or tobacco users availability of those resources. And the information gathered by these hospitals demonstrates a very large increase in the percentage of patients who report receiving support and cessation strategies from their healthcare provider to assist the smoking cessation and to reduce tobacco use. More lessons that you have provided to us in terms of your experience with disrupt. One local health department has been providing more access to health education programs focused on tobacco cessation through their mobile clinic. However, they have learned the importance of family involvements in the programs that focus on behavior change. Next, I want to talk about infectious disease and tuberculosis in particular. Here again, some bad news, an increasing trend. Although it may seem as though 1,334 reported cases of tuberculosis might be what you'd expect, or maybe even less than you expect in a state the size of Texas, the number of TB cases can easily increase if the disease is not treated and controlled. And I think we're constantly trying to battle against it and sort of keep that genie in the bottle as much as we can. And the number of cases in 2015 in our state was, in fact, a 4.3% increase over the number reported in 2015. And here you can see again another example of health disparities. I hope you can all sort of read various lines there, rates that relate to various ethnic groups: white, black, Hispanic, Asian Pacific Islanders, and American Indian and Native Alaskans. And you can see there's a significant the higher rate there among the Asian and Pacific Islanders. Risk factors also associated with tuberculosis. Again, foreign-born only in the sense that other countries have an even bigger problem with tuberculosis than we do, and so many folks import the cases of tuberculosis from their country of origin. And I've discussed during this presentation how certain factors and behaviors impact health outcomes. As demonstrated in this table, DSHS has identified several different risk factors that are associated with TB cases that have been reported in Texas. In this case, where you're from, your country of origin has a significant impact on it, as well as does alcohol abuse, diabetes, and being in jail or prison are also factors associated with increased rates of tuberculosis. Another lessons from DSTRIP here. Due to the transient nature of many latent tuberculosis infections, patients, the transient nature of those patients, rather, tracking and follow-up will continue to be a challenge throughout the DSTRIP year 5. This has led the partner in this DSTRIP project to recruit more community health workers to assist in adequately addressing patient reports. And most of the TB-related projects, getting flickering here, most of the TB-related projects focus on preventing TB disease by addressing that latent tuberculosis infection. And although we we oftentimes at the level of public health put our biggest emphasis on those active cases, in other words, the folks who we know are contagious because of the state of the disease that they have. It's really tracking down the folks who aren't yet contagious but harbor the TB infection that is one of the biggest challenges, because that's by far the largest number of people. But if you can get to those folks and treat them, you're going to vastly decrease the chance that they go on to have active disease. And some of the projects that are dealing with latent tuberculosis infection are increasing the targeted testing of LTBI in high-risk populations, providing routine treatment through a 12-dose, 12-week regimen, and collaborating with DSHS regional staff to use community health workers to best meet the needs of those populations. In measuring the success of these latent tuberculosis infection-related projects, a baseline for some of the new and shorter treatment regimens needed to be established. On average, the baseline for treatment completion rate across several of the projects was 62% in DY3. After measuring treatment initiation and completion, the average percent of persons with latent tuberculosis infection who initialized and completed the treatment in DY4 was approximately 78%. Again, a remarkable achievement, in my opinion. The overall increase in the percent of patients who completed a course of treatment ranged from 11.5% to 44.3% across the various projects. I like this chart. I think it really says it all in a way. You know, what's on the left there, I think, is what people who pay for these private projects expect, is this straightforward, sharp rise and improvement. And on the right, we can see those of us who are there in the trenches and really trying to work clinically with patients to make the success come about. It is a learning experience to figure out how to make all these pieces of the system fit together. I think, though, in many ways, I know where I came from before here in a hospital system, it was patient, and their experience, and getting to them and understanding what their experience was like, finding out what they needed in terms of their understanding of their disease and how to navigate the system. So that's it. Again, thank you very much. I have just incredible awe for the depth and breadth of the projects that are out there in the state. Like I say, I had some very early involvement in it, and I don't think I was alone amongst the people sitting around the table and thinking about what could be done in terms of saying, well, is this really going to happen? Are we really going to get results out of this? Are the communities and the providers going to come together and make this happen? And the fact that not only are you all here, but we have very objective evidence that you're fully committed to making these projects work. And I think you're on the cutting edge of doing exactly what we intended to do, which is to learn how to transform healthcare in Texas. So thank you very much.
We have some time.
And now I'm going to do a medley of my greatest hits. No.
We have
Take any questions. Make them. Remember, I've only been commissioner for less than a year, so don't ask any hard ones. But seriously, are there any questions?
raise your hands high if you have some questions. We'll bring you a microphone.
I guess I got the microphone. I'm going to go first. My name is Deborah. I'm from Odessa Regional. Hello, Commissioner. I'm over here.
Where?
Hello.
Okay.
I know I'm
Sorry.
short, but, you know, here I am.
What? People, they were fooling me. Several people had microphones and their lips were moving, and I was very confused.
Actually, my question's related to the tuberculosis statistics that you gave. Is that directly correlated to the influx of refugees that we have from our Asian countries abroad? And when they come in, aren't they screened for that? And how do we track them?
The influx of, the question was about the influx of refugees. I don't believe it's necessarily due to refugees per se. Of course, refugees is a term of art, if you will, and refugee status is different than the status of other folks who are immigrating into the United States. So the number of refugees is, I think, relatively small compared to the larger number of folks who immigrate on other bases. So I'm not aware of any direct correlation with the refugees themselves. I do know that when they come in as refugees, they are screened, medically screened. That's a federal program, that's not a DSHS program. And I can't speak specifically to tuberculosis per se in terms of treatment, but I know they are screened for it. Next question.
Hello, thank you. My name is Melba Price. I'm with Evercore. We do utilization management across all kinds of services and tests, et cetera. But I had a question about your presentation. Very interesting, all the different disease states, et cetera, and how we're tracking and how we're trying to reduce incidences. But on the obesity and the diabetes one, I wondered if you could expand upon what are some of the things some of the projects are doing to actually get us away from diabetes, to get the weight down so that diabetes actually goes away. So I was just wondering what some of the projects are doing to achieve that.
I can't give you a list of all of the district projects that are related to diabetes. I mean, I sort of have that high-level summary here. I would say, though, as a general comment, when we look at the problem of obesity, overweight, obesity and diabetes, we're looking at a trend that's been going on in the United States for decades now. And it's a particularly difficult one, in my opinion, to tackle, because when you think about it, you never have to pick up a cigarette in your life. You never have to take a drink of alcohol in your life, but you've got to eat. And so eating is something that all of us do. And the difference between eating at a healthy level and having your caloric intake match your output during the day, in my opinion, there are just an enormous number of social and economic trends that have created pressure away from the kind of social circumstance we would see in this country very commonly 50 or 60 years ago. Again, where people are preparing the meals in their home, kids are going outside to play, and there's not nearly the temptation to sit in front of a TV screen and play video games and eat, I won't name the name of the snack I think is the most evil snack in the world, but you get the idea. And so how do we change that behavior, I think, is especially challenging. And personally, I think it's another example that's true of many of the things that we're trying to transform here, is that we can't medicalize it. We can't just say that it's about going to the doctor and having a conversation or getting a prescription or even getting a list of healthy things to eat. Clearly, I think everybody realizes that's not nearly enough. And to sort of make a long story short, I think the success that we'll enjoy will ultimately come when we sort of transform society's way of looking at this in a similar way to the way we transform society's way of looking at smoking, for instance. So smoking was a normative behavior 50 or 60 years ago, and now it's something where, you know, your friends will tell you right out, let alone your family, that's bad for you, and you really shouldn't be doing it. And so if we can find ways to help people cope with, again, what I believe is often a sense of stress, a sense of alienation, the inability to go out and blow off steam and exercise and have a physical outlet to burn up all of those kind of calories. We have to partner together, and so it's not going to be medicalized. It's going to be a very broad social change and partnership. I got to listen to the Surgeon General as he came here to town several months ago and speak, and light bulbs really went off over my head when he was talking about the idea that in public health, we have some limited ability to influence change directly in terms of various public health programs, but on broader issues, obesity and diabetes being one of them, I think our role in public health is to be a collaborator and a convener and bringing things together. And I think the district projects are a great example of that, really have convened people around doing very specific, demonstrable things that then produce an evidence-based platform on which to learn.
Dr. Hellerstedt, my question is around
Oh, there you are.
around navigation. When you were talking about the social determinants, and then as you got specific into different diseases, you talked to use the word navigation, education, access. And I think for a while we have all been looking at navigating and educating very disease-specific conditions. I think that many of our projects do that and build upon what we've been doing. But you know, one of the things that we continue to see, and I think one of the things that hopefully the waiver has done and will continue to do, is kind of unsilo that education in that need for access. Because I think what we're finding, in specific, you know, in a couple of areas in our region, is general access. People, you know, you can build the clinics and you can hire the doctors and you can do all the great things with the projects, but if people don't know how to use them properly, there's so many, you know, missed opportunities. And even with those that purchase healthcare coverage now through, not only in Texas, but other states through the exchanges, whether it's a state exchange or the federal exchange, you know, they purchase, many of them purchase, but where the education to properly use it and to break the patterns. And so I just wanted to, you know, to raise that issue. And it, like I said, it just touches so many things I think you mentioned today.
Thanks. I think the idea of education is a big one. I'll stretch my neck out and say, I think we should be teaching people in the public school system things about their health so that they learn how to use the system correctly. And I'm talking about some really simple stuff. So for instance, as a physician, it was quite common to encounter folks where you really had to kind of coax the whole history out of them, you know, rather than rather than having as common knowledge in the society, just as people know, you know, green means go, yellow means slow down. No, it means speed up in Austin, but and red means stop. You know, that's sort of common knowledge, but people don't understand and say, okay, well, I'm going to the doc now and I have this complaint. When did it start? What makes it better? What makes it feel worse? And that's real simple. But I think that's almost a level on which if I could do something about it, that I'd begin to change and educate people. And then I think when they would be able to explain themselves better to the physicians. It wouldn't be a mysterious and intimidating encounter the way it often is. Doctors would feel less frustrated because they'd be getting a lot of the information that they needed in kind of the way that doctors need in order to help think about what we call the differential diagnosis. In other words, here's your set of complaints. How many, you know, the better doctor you are, really the longer list of things that you can think of in terms of possibilities, and then you start asking some clarifying questions. So that to me would be a really basic place to start, and I think beyond that, then people would have a better sense of how to navigate the system. I personally find a lot, as was mentioned earlier, I think you mentioned it in the conversation at the table, which was you get kind of conflicting information. You got a lot of people that are out there trying to tell you the right thing to do and give you good information, but it's your insurance carrier versus some other caseworker versus some other entity, the hospital that you just got discharged from. And those folks aren't necessarily coordinating their messages or, to folks, and sometimes they're actually giving them contradictory information. So having a unified system that really can help navigate people through and speak to them in language that they can understand.
So we know that about 80% of our health is determined by something outside of a clinic, and yet we spend about 5 cents out of every dollar for prevention and the other 95 cents for clinical care. Do you think DSRIP is a direction that might change that, or how do we change that? Because without it, we're going to continue to put money down the medical black hole. I'm a physician, by the way, down the medical black hole and not achieve the kinds of changes in terms of social determinants of health that really will move the needle.
I think that's exactly correct. And again, it goes back to saying that not only from the standpoint of public health from my agency, but really even from the standpoint of the healthcare professions, physicians, hospitals, and that sort of thing, we ultimately just need to be collaborators and coordinators of a larger social and economic impetus to try and do something about this. You know, I was speaking to a person the other day who's very interested in putting together those kinds of collaborations, and she had a lot of experience and direct contacts with you know, employers, very large institutional employers in the state of Texas, and was pointing out how her message to that group was going to be, you need to understand how important this is, because otherwise you're getting a workforce that is going to not be productive and is going to be very, very costly in terms of its health care. And so if you want the best kind of workforce, you've got to understand how that is connected to these health outcomes.
Hello, Dr. Hellerstedt. Thank you for coming here as a public health guy. It's nice to see the state health department represented, so we appreciate that. I know Ayana's presentation about, population health was defined in 2003, and I was thinking, a little bit longer than that in terms of the parallels to public health. My question is about how do you see that we can build the public value proposition for the public health, building off the question from over here. In my county, we spend 10 times as much on the animal shelter, on dogs and cats, than we do on public health and actual humans that need the help. So I think, I can't wait to see the report on what the impact of expanding Medicaid would have been had we done it. I think, spoiler alert, it would have helped. But politically, that's completely untenable in this atmosphere. So that goes back to kind of building public support and public value for public health as a kind of a non-political thing, even though we do help the most vulnerable. Thank you.
Well, I think it needs to take place on multiple fronts. So DSRIP is a key piece of that, though, because it is, in fact, investing in some of the missing pieces in terms of the healthcare system of putting people together, helping them navigate, really having a cogent plan of, well, how do we actually reach out to people and do a better job on this or that particular project. So DSRIP, I think, is a real key piece of it because it's talking about the science of improving the way in which care is organized and delivered. So that's a major piece of it. I think there are many other fronts on which we need to work, and that collaborative effort that I was talking about, I think, is a big piece of it. Again, I don't want to be a pessimist, but I think, in my opinion, I really have to face the fact that a lot of the trends we're seeing are the result of social and economic trends, trends in the family, trends in the workplace, trends in the school, trends in the neighborhood that have been longstanding and have existed for decades and have created a tremendous pressure on folks in terms of what they should think is important, how they spend their leisure time, what they put in their mouth, what they do for recreation. And there's an enormous pressure behind that. And we have to have a force that's equally effective at changing some of those dynamics. Other folks? All right. Very good. Thank you again very much. I appreciate it.
Hi, everybody. I'm going to walk you through the agenda for the rest of the afternoon. Starting at 1:15, we're going to have best practice and technical assistance breakout sessions. One here in the ballroom, which we expect will probably be of high interest on developing your business case for value-based purchasing and alternative payment models. Second session is on social determinants of health. And the third one with the Baylor Scott and White team is successful outcome measurements and validation. After that, we'll have a short break. I need to remind RHP 6 that they need to come here to the podium or hereabouts for a picture. And then from 3:15 to 4, it is time for you to meet with your RHPs. At 4 o'clock, John Scott and Ardalis Kalsa will be here to answer any questions that you guys have come across over the course of this conference, and then we will wrap up and adjourn. Thank you.